According to the American Cancer Society, pancreatic cancer deaths account for 7% of all cancer deaths. It is the fourth leading cause of cancer death in men and in women.
On this week's Health Talk, we'll discuss the increase in incidence of pancreatic cancer and what's being done to address this.
So stay tuned. We're up next.
Hello, I'm Dr. Andrea Peterson.
And I'm Dr. Eric Mazer. Today we're going to talk about pancreatic cancer with Dr. Richard Frank and Dr. Frank Cannizzo. Got that right? Thank you both for joining us on the set today.
Thank you so much. So, Rich, maybe you can start us off by talking a little bit about pancreatic cancer and why are we so worried about pancreatic cancer increasingly?
Yeah. Well, it's estimated to be the second cause of cancer deaths by 2020 because we haven't made great strides in treating it and increasing the cure rate.
So we're seeing lung come way down because people stop smoking and colorectal coming down?
That's right.
Because of all the screening we've done.
And breast cancer survivals are improving. I guess pancreatic cancer often presents when it's not surgically, it cannot be taken out because it has spread already. About 20% do present where the person has jaundice or abdominal pain, an early sign, and we send the patient to the surgeon to take it out. But in most cases, that's not the situation. But that's part of the reason why it's so difficult to cure.
Frank, I suspect most people have heard of the pancreas, but many people have no idea what it does. Maybe you could tell us a little bit about some of the basic physiology, and then we'll talk about how do you treat it surgically and in other ways.
Well, the pancreas is one of the digestive organs. It helps us digest proteins, helps us digest carbohydrates. It has a role in digesting fat. It also houses the cells that make insulin and glucagon that regulate our blood sugars. The location of the pancreas in the body sort of explains why it's such a difficult organ to treat. It's right in the center of your stomach, liver, small intestine, large intestine. It is about as far back in your body as you could get, so it's covered by all of the other organs. And it's relatively small in terms of how large the other digestive organs are. So often problems with that are pretty difficult to detect until
I've heard it described as living in the arms of the duodenum, which as you said, the intestine.
I don't think your audience appreciated that.
Maybe not. The duodenum curves around. Actually, there's an off-color part of that too, which I'm not going to say on set.
Rich, who's at risk for pancreatic cancer?
So about 5 to 10% of pancreatic cancer has an inherited component. Families have first-degree relatives, parents, children, or second-degree grandparents, cousins, where there's a clustering, and you know that you have a family pancreatic history.
Is it usually younger age as well, like so many of the family cancer syndromes?
Yes, and some of those it can occur also before the age of 50. So when that occurs, that's clearly a family that may be affected.
I know that we know that the BRCA gene can be associated with pancreatic cancer. For these other clusters, do we have a genetic, have we identified the gene that predisposes these patients?
Right, so there is not yet a test for a person who has pancreatic cancer in their family strongly. We cannot test that family for a gene. We don't know which genes cause pancreatic cancer or predispose to it, as opposed to hereditary breast or ovarian cancer. There's the BRCA1 or 2 genes where you can test and say some family members have it and some don't. But regardless, it's the history that qualifies you as a family pancreatic cancer family for which certain screening may be recommended, or at least it's in the research stages, something we just talked about. Anyway.
And Frank, genetics aside, are there environmental factors, lifestyle factors that increase the risk of pancreatic cancer?
Well, smoking certainly increases the risk. And with respect to the cancers that are smoking related, pancreas is a very, very sensitive cancer. And the risk begins to rise when you finish your first or second pack of cigarettes. So whereas most other smoking-related cancers are related to pack years of smoking. Also, alcoholism, diabetes is a marker of people who might be at risk. It's unclear, I think, whether it's related to causative factors.
Tell us a little bit more about that, because I think that's interesting.
Well, Well, having diabetes for a long time, 20, 30 years, really raises the risk factor 1.5 to 2 times, so not tremendous. But looks like when a person is first diagnosed with pancreatic cancer, it's those first 2 to 3 years where their risk is exceptionally high. And so that's the target of our pancreatic cancer
So we
screening
don't know whether
project.
it's causal or we don't
Yeah.
know whether it's the chicken or the egg. We just know that that's an association.
There is some science that says that the developing cancer sends molecules to the insulin secreting cells to affect them. So it is felt to be due to the developing cancer,
Okay.
different than type 1 or 2 diabetes.
And what will patients notice? I think part of the problem with early diagnosis, maybe you can both chime in on this, is it sits deep. It can be a relatively silent organ with stuff going on there.
Well, the classical signs of pancreatic cancer are painless jaundice, where your skin, eyes turn yellow.
Because the bile duct goes through the pancreas and the cancer blocks it off.
And occasionally there can be pain or fullness, but those are usually very late signs.
You know, back when I was a medical student, they taught us that tumors in the tail of the pancreas would present as depression. I don't know, that always seemed to be a very loose association, and given the number of depressed people that are out there, do you think that has any validity?
No, but I'll tell you something that is interesting.
Okay. I'm sorry to be boring, but just
If somebody all of a sudden loses the taste for cigarettes,
oh yeah,
that is a marker of pancreatic cancer.
I've learned that as a lung cancer one too. That's
Maybe
interesting.
a bunch of them, but
Yeah.
that's an interesting one. The depression, maybe, I don't know.
Yeah, and it's interesting because these cancers can have complex metabolic effects, weight loss, unexplained weight loss. I'm sure you'd worry about that. It is interesting how these tumors can cause these systemic effects that can be subtle and progressive. But it is a problem. People don't come and say, "Oh, I've got pain, right here in my pancreas," that often. I guess they can, but
And it could be kind of vague, subtle pain for a while. People may attribute it to something else, when should somebody who might be concerned about pancreatic cancer start seeking help? What should they do?
Well, they can call our research office, 852-2148, because we're running a clinical trial for pancreatic cancer screening to try to catch it early.
yeah, this is really important because typically we don't screen for pancreatic cancer. These are patients that maybe if they saw their general doc, their internist, the doc may not do it, or their insurance might not cover it. With the research protocol, that's actually covered, right? So this is
That's right.
and if you see something, you'll tell them.
That's right.
So if you see something, say something, right?
Yeah, no, this is in real time. I mean, this is, if someone has an abnormality, we're all going to review the MRIs that they have, and if it's a suspected area, then a person will get an endoscopic ultrasound, and if it's proven cancer, then they meet with the surgeon. But that's the study so far.
So this is say again, Rich, how does somebody who's worried about this legitimately because of pain or weight loss or
Well, I think the
they've
first
lost
step
their
is to
taste
go to
for-
their doctor,
yeah.
get a blood sample, make sure there's nothing else going on. There could be 100 other things. But if there is the suspicion of pancreatic cancer, either for a genetic reason or if there's the new onset of diabetes, they will be screened by a research nurse for our study.
Sometimes people have pain and they wind up getting an ultrasound or a CAT scan, Frank, and that may show a mass in the pancreas. Would those patients be eligible for this to call you and be in the study?
No, because it's a screening study, so we don't know that they have pancreatic cancer.
Then you should call Frank.
Then you call
So
Frank
he can-
directly.
So he can take care of things definitively. But what are the things you think about when you first see a pancreatic cancer patient? You tend to see them after somebody's found the mass.
Right.
Are most of them biopsied by the time they get to you through an endoscopic biopsy, or do they often you just get a mass?
It depends on where the patients are coming from. If they're coming through our system, then they come through in a fairly regimented way, and they are usually have already undergone a biopsy or at least an endoscopy with, some collection of cells. If they come from outside in the community, then it's variable. They may or may not have already had a biopsy. They may or may not have had appropriate imaging, and then we bring them in and just start from where the next step that they need to get to.
And it turns out that pancreatic cancer, like many, if not almost all cancers, they are best handled by a multidisciplinary team of radiation oncology, medical oncology, surgery, pathology, and you guys do that at Norwalk. I presume the same thing is done up at Danbury Hospital. But tell us a little bit about this multidisciplinary approach to pancreatic cancer, if you would. Rich, you want to start, and then we can.
Well, there's GI. We have a GI tumor board frequently that discusses those cases, and as part of the study, we're going to be developing a specific screening tumor board.
By the way, the patient, just for people, they're not charged for this extra review. This is just part of the ethical, modern treatment of cancer.
Right. The model for treating cancer in North America, Europe, most of Asia, has evolved into one of shared decision-making and constant discussion among cancer-specific professionals. These are, people who've devoted their careers to studying these particular kinds of cancer. And periodic review of initial patients coming into the system, as well as patients at various points along their cancer treatment journey, is key to making sure that every patient gets all of the treatments that they need, gets none of the treatments that they don't need, and gets the treatments in the correct order with the correct timing that'll likely generate the best possible outcome.
So I think this is a good question for patients to ask their doctors when they're referred to a cancer center. That is, whether they manage those cancers in a multidisciplinary way with multidisciplinary teams. Yeah. I went through an interesting exercise years ago where we had a problem to solve individually, and then it was an exercise, and then we did it as a team, and every single instance the team outperforms the individual. So I think the idea of a team decision, and this isn't just bringing more of the same minds, you're bringing all the disciplines. I can't think of a better way to decide how to manage a patient like this.
And I just wanted to mention, though, that while Rich and myself and the radiation oncologists are key players in this, it's really much bigger than this. The diagnostic radiologists, the gastroenterologists, oncological nursing, nutrition, palliative care, pathology, all of the disciplines regularly get together and discuss these. It's not
so you're even able to bring in personal home aspects, family aspects into these decisions?
Sure. Absolutely.
And that's so important. I think, patients and families may not know that this is happening regularly, and it's really everybody physically coming together as well, not just talking haphazardly, but really coming together, focusing on one patient at a time and the totality of what's going on with that patient.
I think patients would be very reassured to see what these discussions are like. The depth. I've obviously been to many of these in my lifetime, and the level of depth and expertise that's brought to the discussions are really quite profound.
Yeah. Now it's growing and growing as we hire, experienced surgeons and other doctors. Where the network is growing, the hospital's growing, and affiliations are happening. So there's more and more expertise at our hospital.
It's really, this is part of the general evolution of medicine from one-on-one to team kind of care. And I know that the doctor-patient relationship is sacrosanct, but this team approach also brings an awful lot more to the table. For complex illnesses, I don't think you need a group of people getting together to worry about a cold or a strep throat. But for something like pancreatic cancer, this is there are a lot of subtleties. So now that I've talked too much, we'll ask our guests to stay for the second segment. And really, we'll talk hopefully a little bit more about treatment, some of the things that you do, which I can't imagine, the Whipple procedure, which is one of the biggest procedures that we do. So stay tuned, and you'll hear more about this and the treatment of pancreatic cancer.
Don't go away. We're back with Dr. Richard Frank and Dr. Frank Cannizzo. Welcome back.
Surgeon, medical oncologist. Maybe you could talk about some of the considerations, the surgical considerations, when you see a patient with pancreatic cancer. And how do you get involved early on, or are you involved? I know you're involved early on. So tell us how you coordinate things and how you think about a patient who comes in with a pancreatic mass. Maybe you know that it is an adenocarcinoma, a typical pancreatic carcinoma. What are the considerations then about the treatment?
Well, the focal point is the surgeon. Frank will talk about, he reviews it and makes a decision about surgery now. Yes, no, and what the branch points are from there.
Well, my decision making is pretty straightforward. It relates to three parts. It's whether the operation is technically possible. there are certain structures in the body, I'm sure you can imagine, that you can't take out. So if your tumor involves those, then it's not technically resectable. You have to be able to leave the patient alive and somewhat intact. So technical resectability. Then oncological resectability, which relates to whether a tumor that it's technically possible to completely remove will do any good. I mean, there are lots of cases where we see patients who have a pretty reasonable sized tumor with 1 or 2 metastases, which in this day and age are technically resectable. But we know from long experience with pancreatic cancer that surgery on patients who already have metastases doesn't change the outcome of the disease. That disease properly belongs in Rich's.
And maybe you could, 'cause I think the unsophisticated, I don't want to sound pejorative, but the unknowing person would say, well, you've got a little thing, why don't you just scoop them out, right, take out the tumor, then at least I'm disease free. And they don't understand what you're saying. Why does it change the course of the disease?
Well, because we know that the metastasis that you can see is only a marker of a much larger complex of cells that have already left the primary tumor and lodged in multiple places in the body, mostly in the liver, obviously, but all over. And we know that if we go and resect those tumors that are visible, others will pop up over the course of a very short time, weeks to months. And
they pop up because there have been metastases by single cells, right, that we just don't see. It's been seeded, but it hasn't grown. So you see the good ones that have grown, but you don't see the ones where there may be a cell here, a cell there.
So the person who's a candidate for surgery is really somebody who has a technically resectable tumor, and just that one, mm-hmm, just in the pancreas.
Yes.
And you said there's a third.
And just as important, the tumor, the case has to be medically resectable. It has to be somebody who is healthy enough to undergo the rigors of a very big operation and a fairly prolonged recovery. Yeah. So it doesn't, like we said at first, and I don't mean to be flippant about this, but one of the key considerations is being able to do the operation, do it correctly, do it completely, and leave the patient functional and intact at the end of the day.
And you don't do it if there's no hope that it's going to cure them or have a major impact. So what percentage of all pancreatic cancers, people that are said, meet those standards of being resectable, that you can take them out?
20%.
So unfortunately, 80%, it's incurable from day one.
Right, but there's a middle category now of individuals who have a tumor that is involving critical blood vessels that cannot be removed, but if we administer chemotherapy and sometimes also radiation to that area.
Before the surgery?
Before the surgery. That's called neoadjuvant chemotherapy. About a third of those individuals can then go on to have the tumor taken out, and their survival appears to be the same as those who are able to do a Whipple up
And this
front.
is a little different than the patient who has metastases
That's
already,
right,
because here it's really just that the tumor has grown into critical blood vessels, and as you said, you couldn't meet the criterion of leaving them alive after you take it out.
So Frank, this sounds like this gets at the point you made before, that the team looks at what's going on with the patient and decides not only what's the right treatment, but in what order does it need to happen?
Right. In the past, before we had this kind of structure, not we, the larger we of cancer care, surgeons would see patients and operate on them, and then at the end, bring the case to the tumor board and say, hey, what's next? Well, it's not always the best thing to do surgery first. It's not always the best thing to let one person make all the initial decisions. So that's why before I ever contemplate operating on a patient, we talk about it as a group, because it's important to get everybody else's perspective. I know a lot about pancreatic cancer, but I'm not a medical oncologist. I don't see things through Rich's lens.
Well, what's it like to tell a patient that they can't be resected? I mean, you said 80% of people come along, and we go through this process, and you have to, I guess, Rich, you end up sitting down with them more often than anybody, or is it you, Frank?
Well,
and to say, I just can't, this is not going to be resectable.
I get to tell people that they can't be resected quite a bit, but it's not, The disease that they have is the reality in the room at the moment. So it's not about what we can't do. It's about what's next. It's about, okay, you know, we don't get this, but we get this. We get chemotherapy, we get radiation. These are the numbers. Things are better if we treat you than if we don't treat you. The ball's in your court. You have to make of life what you have in front of you.
Yeah,
And
yeah. 80% of individuals who do get a Whipple do not survive 5 years. Okay, so
So that's of the, and what you're saying is that 20% that goes to surgery,
only 20% survive.
Only 20% of them survive.
So,
Which my
long-
statistics,
that's right.
that gives us about a 4% survival
So we
rate.
all think cancer, get it out. I mean, that's a natural response. And oftentimes that is important to do, but in this cancer, just getting it out doesn't guarantee survival, cure, and may impact quality of life. So as Frank was saying, there are numerous considerations. Sometimes it's better for the patient if it is a borderline case or it's difficult to take out. Their quality of life may be better preserved with an intact plumbing, and their survival would probably be the same. People are living longer with pancreatic cancer that can't be taken out. So it is even though it's the goal, it's it's what people want to achieve when they're first diagnosed. It's not the end of the world if it can't be taken out. There are other pathways to pursue.
Tell us a little bit about those pathways.
There are chemotherapy regimens that have improved survival now. So in days past, we would talk about 6-month average survivals, which are horrible. Now average survivals are a year. Okay, that's still not acceptable, but some people can have prolonged survivals. And there is new research. We're opening a study soon on a cancer stem cell inhibitor. So that's going to be integrated into the standard treatment to see if that can improve survivals. So treatments are getting better. They have a long way to go.
Yeah.
But
Well, why don't we just treat this like breast cancer and, you know, take out what we can see and then give chemotherapy to wipe up the remaining cells? Why does that work?
That's a great question, and it comes back to an old saying in the cancer world that biology is king. The behavior, the potential of pancreatic cancer cells is very different from that of breast cancer cells. Breast cancer cells tend to be more organized and more well-behaved. They're amenable to getting most of the cancer out and treating the rest with other means. Pancreatic cancer cells don't. We haven't found the way that we can do that with pancreatic cancer yet.
So that's, again, why research is so very important.
And we have to go to break. So we're going to ask our guests to stay with us, and when we come back, we'll talk more about pancreatic cancer.
Right now, let's take a look at some of the upcoming events sponsored by the Western Connecticut Health Network. This week's health question is, if someone thinks they may be at risk for pancreatic cancer, what should they do?
What should they do? Rich?
speak to their primary care doctors, review their family history, talk about any risk factors that they're aware of. And
Stop smoking?
Stop smoking, lose weight, do the usual things to optimize health. If there is truly a genetic risk or they've developed new diabetes, they should call 852-2148.
So it's 203?
Yeah.
203-852?
2148, or go to the hospital website to look at the screening study that we're.
And if somebody has found out they have pancreatic cancer and they want to be involved with you guys particularly, how do they get referred into this multidisciplinary team, right?
They can literally walk into any entrance of the cancer center, and the staff there will direct them to one of us.
And the pathology will be reviewed again. And
yes.
I mean, again, a lot of people don't realize they're getting second opinions from so many people with these multidisciplinary teams.
Yeah.
And what do you see as the future of pancreatic cancer? Do you think that the first breakthroughs will come through in early diagnosis, or will it be that we finally find some agents that have some activity against these resistant cells?
I think the keys are going to be in better screening, earlier diagnosis, and then everything that Rich can do.
On the back end for new
Yeah.
research findings. So at the end and at the beginning, hopefully there'll be advances at both levels.
And all along the way, approaching it in a very multidisciplinary, team-based approach that is very individualized for each particular patient.
Yeah. And more research needs to be done and more money needs to be given to pancreatic cancer foundations and those supporting pancreatic cancer research.
Any closing comments from both of you?
Pancreatic cancer, like any other cancer that we treat in these days, is a team sport.
Rich?
Thanks for having us and educating everybody on it.
Well,
Yeah.
thank you for
Thank you
educating
both so
everybody.
much. We
It's
appreciate
a
it.
terrible disease, but it's glad to be focusing on it, because I think
Right.
people tend to focus on the stuff they're having success on, and I think it's really important that we do focus on these resistant disease. So if you at home have a question you'd like to ask us on Health Talk, please contact Andrea and me at healthtalk@norwalkhealth.org.
I'd like to thank our guests today, Dr. Richard Frank and Dr. Frank Cannizzo, for coming on the show. We really appreciate their expertise.
We'll see you next week on Health Talk.